a great pleasure to be part of this online meeting again. The topic I'm going to present on is the topic of intracranial hemorrhage. And I'm very pleased to do so, and I will do it from the perspective of a radiologist using fetal MR. I would like to present on first, how can we detect fetal brain hemorrhages? Then I would like to talk a little bit about the types of intracranial hemorrhages and how to grade them and assess them and describe them. And then I would like to spend some time talking about prognostic issues and the consequences of fetal brain hemorrhages. I feel myself as part of a fetal neurology team. A fetal neurologist is not a radiologist. A fetal neurologist is also not a pediatrician. It's not a MFM specialist. It's a team of people. And I think in the future we should keep this team approach. And I feel that a fetal neuroradiologist should be also part of it. Intracranial hemorrhages are usually can be detected by ultrasound. And there has been a paper published in the year 2020 by the group of Amsterdam, saying that neurosonography in good hands is equally sensitive to pick up brain hemorrhages compared to MRI. It was published in Ultrasound in Obstetrics and Gynecology, and this is certainly a reference paper. If you look into the paper, you will realize that they used T2 and T1 weighted sequences in 3 directions and the diffusion weighted sequence. Here you can see one of the examples of that MRI image compared to an excellent quality ultrasound image. Now, if you go further into detail, let me describe you what is missing in this protocol. T2, T1, and diffusion. Here is a case at 36 gestational weeks. This is a T2 weighted sequence, and it's clear to us that there is some hemorrhage going on in that ventricle here. What you also see is that we can assess the aqueduct and its patency. Currently, it seems that this aqueduct is patent. What we did not see in all these images, that surrounding the brain, the entire cerebellum, the entire brain stem, and even the third ventricle here, is lined by a dark line only visible on EPI sequences, echoplanar sequences, which was never detected on any other sequence, T2 or T1. This means we have a sequence which basically can see hemorrhage or blood degradation products better than any other sequence. And this is the EPI sequence. Tim Doritke from a team performed a study where we retrospectively analyzed brain hemorrhages in fetuses, comparing the normal T2 weighted sequence to this EPI sequence. And what we basically found was that EPI T2 star picks up 30% more hemorrhages than the conventional T2 weighted image. This needs to be kept in the back of our head when we compare ultrasound and MRI. We have to know that by comparing T2 weighted normal sequences to neurosonography, we have a somewhat similar performance with neurosonography in good hands. If you have MRI in excellent hands, though, using EPI sequences, and that's not a big deal, this sequence takes you 20 seconds, you're able to pick up 30% more hemorrhages than the conventional T2. And that, in future, of course, needs to be accounted for. We have, of course, to say that the majority of those hemorrhages are grade 1 and 2 hemorrhages. These are about 58% in our cohort. Here's an example, T2 weighted sequence showing a little bit of ventricular enlargement, the EPI star showing the hemorrhage right here. in the ganglionic eminence region. And another case, a little older fetus on T2, you see unilateral ventriculomegaly, no sign of hemorrhage here on the T2, but with T2 star, clear lining of hemosiderin blood degradation products, indicating that a hemorrhage has happened here. So with whomever you're working with on fetal MRI, make sure that they are working according to the ISO guidelines, which require the EPI sequence, taking you between 10 and 20 seconds of time effort on the fetal brain to be able to assess the presence or absence of blood degradation products. Two different other sequences with a conventional T2-weighted sequence, both cases appear, well, there are some changes here along the ventricle. You see a wider ventricle in this case, and here in the earlier examination, also a little bit of widening and some irregularity on the ganglionic eminence. But look at the EPI. This is absolutely clear that there has been blood here, here, and here. So really, this sequence is worthwhile to be used in the evaluation of babies with blood and with hemorrhages and ventriculomegaly to find the reason for ventriculomegaly. This is a higher resolution of this EPI sequence, takes you a little bit more time, but also gives you really an excellent contrast here. The latest development, and that is really the latest cry in MRI, it's not available to everybody, and therefore I'm just mentioning it, is SWI. This is a technique which we use in adult imaging a lot. In fetal imaging, it's not routine, but what it adds is that we have more certainty. In this case, we are not so sure whether or not this is hemorrhage, and if we may overcall this. With the SWI, we did not detect any blood here, but we definitely detected blood degradation products here. So this was the case which was correct positive, and this was wrong positive. So the SWI gives some more specificity to our findings. The EPI is a very sensitive sequence. SWI is very specific, and I think that's the way we're going to use it in the future. Now, let's get into the meat of the problem, and that's the typical intraventricular hemorrhage. Intraventricular hemorrhages for a long time were known to happen in preterm neonates, premature neonates. These are examples of different IVHs, all typed and characterized as grade 4 IVHs in these neonates, and this is actually the problem. All of these three cases are graded with the same grade of severity. The origin of this hemorrhage is the ganglionic eminence. The ganglionic eminence is a structure which is transient, which means everybody of us has this structure in our brain, but only as a fetus. We are going to lose it over development. These are some anatomical drawings and images, and this is the MRI aspect post-mortem of this structure, and in vivo. You can get an idea on it by ultrasound, but I feel that the good tissue contrast by MRI allows us to segment this structure in a three-dimensional way with a clear discrimination of its order, and by that it allowed us also to do some volumetry, which Marlene Strümpflen was able to recently publish in the White Journal. You see that the ganglionic eminence is quite thick at around 20 weeks and gets smaller and smaller over time. There's an inverse relationship with cortical growth, so the smaller the ganglionic eminence gets, the larger the cortex is becoming. What is the peculiar thing about this structure? The peculiar thing is that, and these are images done by my wife, who is a pediatric radiologist. So you see, I'm not only into MR, there's a big interest on ultrasound on my side as well. And I see the fascinating developments here. This is a technique called superb microvascular imaging, which she applied on a neonatal brain, a preterm brain. And what you see here is how intensely vascularized the ganglionic eminence is as a structure. And that is also the reason why it is so delicate and so perceptive to hemorrhages. And that brings me to a very interesting view. Most of the preterm hemorrhages, brain hemorrhages, are believed to happen after birth due to prematurity. Babies in the incubator, there are blood pressure differences, there is the out of mother environment, which basically triggers these hemorrhages. That's our main concept of those hemorrhages. But let me bring some other aspects. Our preterm babies are the results of a preterm, or mostly the preterm, premature rupture of membranes. And that goes along with different problems, pulmonary hypoplasia, there is inflammation, and often we observe in the follow-up cerebral palsy. So if we look into some of our cases with preterm premature rupture of membranes, we will realize that in this case at 24+1, the outer CSF spaces are almost diminished. There is no water, no CSF around the brain. The brain itself is quite small, kind of swollen, and the outer CSF spaces are obliterated. We might call that on MRI cerebral edema. You see this situation of anhydramnios persisted here up to 29 weeks, and you could see still that the layering of the brain here is resolved, and that is due to the amount of accumulation of extracellular water and brain edema in the fetus. What you also see is that there and here there might be a hemorrhage. What are we doing? We are using EPI, and here, of course, we can see this hemorrhage much, much better. And if we even extend it to a diffusion-weighted image, we realize that around these little hemorrhages, we have even a small infarction. PVHI, perivenous hemorrhagic infarctions, are the result of these local brain edemas. I believe strongly that this has to do with venous congestion, meaning due to the compressed state of the fetus, the absence of amniotic fluid, and the absence of the outer CSF spaces, venous backflow is not ideal, and therefore we have congestion, we have perivenous hemorrhagic infarction and intraventricular hemorrhage as a result. So some of our preterm premature neonates may not have their hemorrhages develop after birth. Some of them may have them already before they are born as a result of their anhydramnios. Another observation supporting this concept of venous congestion is a study performed by Shi Hui from China. We're visiting our department, and she looked at Chiari cases, such as those here. You see, here is quite a bit of space around the brain, but here the outer CSF space is absolutely diminished. Now, these brains, we call them cases with brain edema. She also quantified it with radiomics and objectified them. They have a propensity to show hemorrhages. And here you see that clearly, again, outer CSF space totally obliterated, ventricles enlarged, but also on EPI, extensive periventricular hemorrhage and blood degradation products. So this is a finding which we also confirmed on post-mortem MRI with this layering of hemorrhage along the ependyma, which means that in Chiari-2, due to the obliteration of outer CSF spaces, abnormal CSF circulation, we have venous congestion. Venous congestion leads to edema. Edema leads to hemorrhage. And that, is, I think, is an important mechanism, and we can sort of recapitulate it on MRI. Here you can see that up to 30% of Chiari-2 fetuses have those hemorrhages, and most of them also showed congested veins intracranially, and also many of them showed signs of brain edema. Another feature in this setting is fetal inflammatory response syndrome. Premature rupture membrane goes along often with infection, inflammation, and this infection causes changes in the brain and many other organs. These changes in the brain, or also in the placenta, also in leading to ascites, pleural effusion, and pericardial effusions, can, in a worst case scenario, also cause brain inflammation, propensity to hemorrhage, and extensive intracranial hemorrhages, as in this very dramatic case, dying right after birth. But let's come back to the grading of these intraventricular hemorrhages. This is the grading we adopt for fetal diagnostics from the neonatal field. This is the grading done in the year 1978 by Lucille Papil. Lucille Papil looked at 46 cases, neonates, and graded them according to the severity of their intraventricular hemorrhage. And what she said is, grade 1 is a hemorrhage which is confined to this ganglionic eminence. Grade 2 protrudes a little bit into the ventricle, but the ventricle is not enlarged. Grade 3, there is more blood in the ventricle is enlarged. And grade 4, the blood goes also into the parenchyma. That's easy, everybody understands it, everybody applies it. Still today, it is the main way to classify an intracranial hemorrhage in neonates and also fetuses. But here is a word of criticism. Look back at the paper of Lucille Papil and look at what was the imaging basis for her grading. And let me show you that. Her imaging basis was neonatal CT. And these are the original imaging examples of her grading. I would say that even a worse ultrasound of nowadays is better than the CT images in the year 78. And remember, CT came on the market around that time. So this was really very, very early. So we have to keep in mind that our imaging technology is totally somewhere else. This grading system is useful because it's easy, but it's not certainly up to the modern technology. Hampassan was updating this classification because he noticed that there are different regions in the brain which are affected, and wanted also to account for that, and used this classification distributing hemorrhages to the different regions of the brain, occipital, parietal, frontal, or temporal. This is a very, very modern way to classify brain hemorrhages in neonates. We applied that in preterm neonates together with the neonatologist. I show you just 2 cases, and you can see here there are many, many different features we have to score on, including the corticospinal tracts, the cerebellum, the white matter, and so on. And we end up with a score here. In this case, it was 22. The higher the score, the worse. And in this case, it was 13. And this is basically our graph showing the correlation to outcome. This is the probability of Bailey scales higher than 70. Below 70, we can expect there's a major cognitive and motor impairment. So you see the age of preterm birth plays a role, but also this score plays a role. Both together act together. And if you look at this case, it would be down here. We have almost 0% that this baby is going to have a normal development, whereas this guy here with a score of 13 is somewhat right here, around 30 to 50% chance to have a basically score up more than 70 on the Bailey scales, which is okay for a neurodevelopmental score. Both, and that I would like to emphasize, would have, of course, been scored by Papil grade 4. And also this scoring system was documenting and proving that it is absolutely superior to the Papil grading. The only problem is you need to be experienced and knowledgeable in brain structures. Then you can use this score in neonates, but also, of course, in fetuses. This would be the transfer of the papille grading to the fetal life. You see IVH grade 1 is almost invisible on the normal T2 weighted sequences. Grade 2, well, here you can discuss if there is already ventricular widening. I feel so this might be a grade 3. The grade 2 here, again, discussion, is this ventricle not a little bit enlarged? Should it be grade 3? I would score it still grade 2, and this was a grade 4. However, this is a simple approach to the problem. We do not currently respect if major pathways, functional aspects of the brain are involved or not. And that is and has always been a job for neuroradiologists to bring together the structural and the functional aspect. And we, in this case, got support by a perfect obstetrician, Efrat Hadi, who analyzed our corticospinal tractographies in IVH cases and found that basically if you have normal corticospinal tracts on fetal MR-based tractography of the pyramidal tracts, if you have normal findings, you have a chance of only 5% to have a motor deficit. Whereas if you have some affection or change of the corticospinal tract detected by DTI, your chance of having a motor problem is much higher. In our cohort, it was 30%. I just give you an example here. One case imaged twice at 23 and 33 weeks. And you can see nicely there was a partial affection of this right-sided corticospinal tract affected by this intraventricular hemorrhage and some periventricular infarction and some destruction of the corticospinal tract. This guy was developing quite well, was walking quite late at the age of 3, however, is now in kindergarten and can be basically involved in normal social activities, but there are some motor deficits present. Let's come to the different types of hemorrhages. I talked about IVH a lot because it's really the type of hemorrhage we see also very frequently. This is another type we see frequently in fetal imaging, and that is a cerebellar hemorrhage. And I like these images provided by Professor Dieter Bettelheim in Vienna to me, because they really document how rapid the involution of a very acute hemorrhage in a fetus is. At 21 gestational weeks, you can see that the hemorrhage is basically getting smaller and smaller and smaller, almost invisible. At 29 weeks, you don't even see any blood degradation products, you only see the defect. But keep in mind that the majority of these hemorrhage signs are resolved within the course of 3 days. That is very fast. For MRI, I would say it's too fast because after a couple of days, we still see a lot of hemorrhage. This is the same case imaged by MRI, and you see we see clear hemorrhage signs days after the ultrasound finding. And at the late stages, we see again also the defect like ultrasound, but here what you also see is on the EPI sequences, which are so sensitive to blood, the T2 star hemosiderin degradation product, indicating that this was an hemorrhage. So that's the good thing about MRI. In the late chronic stages, where the hemorrhage happened weeks before, we still have at 30 weeks a technique which can pick up the remnants of that hemorrhage and make clear that this defect here was not a pure ischemia, it was a hemorrhage. And that plays a certain role because we see more and more of those cases where we think, well, there is a hydrocephalus here, the cerebellum looks abnormal, even the torcula is higher. That is a neonatal image of a classical Danny Walker malformation. This is absolutely not true in that case, because if you look at the prenatal images of this case, you see that at 23 weeks, we could see some hemorrhage of the cerebellum here involving one hemisphere, even sparing most of the vermis at 32 gestational weeks. And by closure of the aqueduct, and closure of the outlets of the fourth ventricle, the cyst of the fourth ventricle was developing secondarily after 32 weeks and was mimicking the image of a Dandy-Walker malformation. So be careful with the term Dandy-Walker again. Be more descriptive. It can be the result of a post-hemorrhagic condition in some cases. In others, it's a true genetic malformation. Here again, a similar situation with some defect of the cerebellar hemisphere on one side. But look at this girl at the age of 5 years. She's doing quite well. Even her balance is quite good. Her gait is okay. Given the fact that half her cerebellum is missing, she's doing quite okay. So we still have to learn a lot about prognostic issues here. These are two different cases. Both are coming from the same mother. First pregnancy, second pregnancy. And you see already on the T2 weighted images that there are a number of different defects in the brain with hemosiderin and also here in the cerebellum blood degradation products. You see the post-mortem specimens here with these hemorrhages. That's how it looks like for the neuropathologist. These two cases were the result of a genetic mutation, a COL4A2 mutation, which is a mutation which leads to a higher risk for hemorrhages. And the pattern, whenever you see a multitude of patterns, whenever hemorrhages, and whenever you have basically a fetal brain hemorrhage, you should also include the possibility of a COL4A2 mutation or A1 mutation as a causing mutation. This was a somewhat similar case without the COL4A1 mutation, but a huge cerebral media infarction, which was hemorrhagic. And look at the postnatal result. You see polymicrogyria here. So brain malformations can be the result of hemorrhages if the hemorrhage is occurring early. And you see with tractography that the pyramidal tract on that side is entirely missing. This guy has a hemiparesis and also severe, almost intractable epilepsy. These three cases have also one commonality. They show a schizencephalic cleft right here, lined by polymicrogyria. And all three cases have fetal MR. And this case clearly also had, in addition to its defect, which was occurring prenatally, a small hemorrhage in that area. So schizencephaly and polymicrogyria can be also the result of hemorrhages. In all these three cases, these were cases of a twin-twin transfusion syndrome. All these cases were basically the consequence of this condition in monochorionic twins, but all three cases were seizure-free. One case, this one with the hemorrhage, was very interesting because there was polymicrogyria, but you could also already see prenatally with the motion analysis that one arm and one leg was moving less than the other. So we were fearing a little bit that as the central region here is involved, that this guy will end up with the hemiparesis. But if you look at the girl here at the age of about more than 1 year, together with her twin sister, you would not be able to discriminate the motor performance of both. Maybe the arm here is not moved as much as in the other one, but generally they are both doing really, really well. And finally, these cases, these 5 cases, they have all one thing in common. Some of them have hemorrhages, I agree. But the thing they have in common, they had a COVID infection. And Patrick Kienast was analyzing our cohort of COVID-infected mothers. And you could see that some of them had the original wild type variants. Most of them had Omicron. And what he found was that in 5 of those 43, this is, of course, a pre-selected cohort, there were brain abnormalities. abnormalities. And the most frequent brain abnormality we found, of course, was hemorrhage and blood degradation products. And we believe that this has to do with the pathology, the thrombotic effect of SARS-CoV-2 to the maternal placenta, causing also thrombi and maybe ischemia, but also hemorrhages to the fetal brain. So we believe that SARS-CoV-2 is a risk factor for fetal brain hemorrhages as well. So let me sum up this. I think it is important to know when you want to detect the intracranial hemorrhage, the EPI or SWI sequences of further development are crucial. There are different types of hemorrhages. Some of them are in the context of premature rupture of membranes, so they occur before birth. Some of them are even subpial in the cerebellum. Whenever you see multifocal images, think about COL41A. And also in premature rupture of membrane, think about fetal inflammatory response system syndrome, whenever you also see effusions or placental anomalies. Another potential cause for fetal brain hemorrhages is the SARS-CoV-2 infection, as documented by the work of Patrick Keenan. And finally, consequences and prognosis in these conditions is not so easy. I feel that the papille grading is solid, but is not really extremely reliable when it comes to prognosing the full extent of the cognitive and motor deficits of these children. We need better scores. I think the papille grading will in future be history. I showed you the images on which it's based on, and I think that our images today, either it's ultrasound or MRI, are much, much better, and we need a system-specific, anatomy-specific scoring system taking different structures into account. Tractography, of course, is a nice tool to also evaluate motor involvement in these cases. And with that, I'm ending my presentation, and I'm happy to take some questions at the end of this session.
That was amazing. Thank you so much, Gregor. Very crystal clear, very really important key messages, and also highlighting so some of the the things that we could see on MRI and how that correlate with ultrasound, particularly with the new modalities. So that was wonderful. Thank you. One thing that I find it really interesting is the last couple of slides of your talk about the COVID and the fact that these fetuses of mothers who had COVID actually had evidence of intracranial hemorrhage. Two really questions. Do you have an explanation of the mechanism of fetal hemorrhage or bleeding with a mother that has COVID? And you did mention even with Omicron, which is supposedly a milder form of the disease compared to Delta, for example. And the second is that, have you published your data? Because I think that would be really interesting.
Yeah, thank you, Asma, for this question. It's indeed a very sensitive issue, as we all went through this pandemic. And of course, I don't want to kind of make people worry when they undergo Omicron infection during pregnancy. And most of the data we have does not indicate that there is an extremely high risk that we have neonatal neurological sequelae after intrauterine COVID infections. However, I just want to point out two things. One study we published in Lancet Regional Health on the placenta in COVID, that was showing that the placenta showed a high rate of MR inhomogeneities, also hemorrhages in COVID-infected mothers. Here it's important to say that most of them we saw with Delta, and few of them also with Omicron. And now out of this cohort, we looked on the brain, and here we found these blood degradation products, which is a thin lining on the ependyma, a little bit of blood there. I can imagine that this has not a huge impact on fetal or neonatal development neurologically after birth. So if you do a meta-analysis, this effect you probably cannot pick up, but it's something we should sensitize ourselves towards. And I feel it's important to, at least in the history of the patient, pick up the question whether or not there has been a COVID infection during pregnancy, to also maybe have a more decent look when there is ventriculomegaly, look for blood degradation products, and think maybe in the setting of COVID infection and ventriculomegaly, maybe do an MRI.
And do you know whether these babies had any sort of clinical impact or the outcomes of these babies? I mean, were they mild or were they severe?
Yes. One case you saw was a post-mortem MRI. That was catastrophic. There, I have to say, there was a severe COVID infection. The mother was severely ill and also placed on the IRC unit. But the baby died. So this was a very extreme course of the COVID infection. Most of the changes we saw were mild. And these mild linings of ependymal hemorrhage, they are currently developing quite well, but we have to reassess that. I think we will finally have data after 3, 4, 5 years. I think we have to give these children time to develop, to draw our conclusions.
One more question, because I mean, this is an area I'm really interested in. Were these babies actually positive for COVID or for the SARS-CoV-2?
So the mothers they were confined with PCR and everything, but the babies are born weeks after the COVID infection. And so we could not prove through invasive testing or didn't want to do invasive testing on them just to prove that they were infected or not. We believe that they probably were not infected, but the placenta was. And that's the mechanism we believe the whole system is acting, so that there is placental infection, placental thrombi. We know from studies that there are changes, and also you, of course, know these studies. And maybe there is some indirect influence through the placenta on the baby, changing the states towards prothrombotic or more towards hemorrhagic states.
That's fascinating, Gregor, and certainly an area where we need more research, more evidence, but I'm hoping that people who are listening to us, that will excite them to go back and look at their data and their cases and hopefully share their research and studies with us. So that was great. Thank you. We just going through the questions from our delegates, and there's a question from ISIS. Are we going to screen every woman for CMV and toxoplasma? I guess preconception, I think. And the answer is no, I don't think so, because actually in most countries, we don't even screen routinely for CMV and toxoplasma during the pregnancy. And there is justification for that, because they don't necessarily fit all or tick all the boxes for the criteria for a screening test. But certainly there is an argument, particularly with the new evidence on the treatment, prenatal treatment and prevention for congenital CMV, that maybe we should relook or reconsider whether we should offer routine screening for CMV in pregnancy or not. The toxoplasma, certainly that's not the case in the UK, and I suspect it varies according to the prevalence of toxoplasma in different countries. Preconception, no, we don't. In fact, it will be difficult to actually screen women preconception, because most pregnancies are not planned. So it would be difficult to test them. But I think what would be important is to highlight and sort of the knowledge and awareness among women in the reproductive age group about the risk, particularly of CMV, because We know that CMV infection early in pregnancy, including in the periconceptional period, is associated with the highest risk to the fetus. And therefore, I think actually waiting until 10 weeks or 12 weeks to teach pregnant women about CMV, I think is a bit late. I think you actually need to make sure she knows about the risk even before she gets pregnant. Another question from Anjana. If the mother is on aspirin and you observe signs of fetal hemorrhage at any gestation, should you stop aspirin? Maybe we should ask Isa Gregor, or actually we do have any, like Anna, for example, or sort of yeah. So Anna or Gregor, or anybody on the call or sort of on the meeting. Do you want to take this question? If you have any signs of fetal hemorrhage and the mother is taking aspirin or low molecular weight heparin, would you advise her to stop it? And I can tell you what I tend to do in my practice.
I'm sorry, I don't have such experience. We don't have many such cases, so I cannot.
And pressure? And Gregor, I mean, is that something that you get involved?
I leave that to you. That's your experience. So I'm a radiologist here. That's certainly not my area.
Yes, you don't have to face the patient and make this decision. Well, what I tend to do, I mean, I think it's the more likely that not that the fetal hemorrhage is not really related to aspirin or the low molecular weight heparin, and I would probably look for other causes before I consider or make a conclusion that this fetal hemorrhage is related to aspirin or low molecular weight heparin, because I believe that most cases of intracranial hemorrhage or fetal hemorrhage that we detect prenatally are actually usually the significant ones, because mild cases of intracranial hemorrhage are usually, I think, missed or not diagnosed prenatally. And therefore, in order to have the significant fetal hemorrhage or intracranial hemorrhage, I don't think that actually the low dose aspirin that we give would be the cause, or even low molecular weight heparin. So despite the fact that there is some evidence now about aspirin and its maybe association with increased risk of postpartum hemorrhage or even intracranial hemorrhage, neonatal intracranial hemorrhage, I think that the association is not very strong, and I think it's likely to be weak and perhaps maybe also confounded by with other risk factors. So I wouldn't necessarily stop it unless I don't find any other explanation for the fetal hemorrhage or bleeding. If I don't find anything, it depends on the risk-benefit ratio. So if this woman is taking aspirin because of, sort of, yes, she has the risk of preeclampsia, but the risk is not high. In this case, perhaps maybe it's reasonable to stop it. If she's on low molecular weight heparin, how many risk factors does she have? What is the dose that she's taking? So, it's something that probably you have to really think carefully before you would stop it, and have to prioritize the mother, I would say, if it's really important. So if she has a history of previous pulmonary embolism, for example, and she's on a prophylactic dose of low molecular weight heparin, and it's a very mild fetal hemorrhage or mild intracranial hemorrhage, grade 1, for example, I'm not sure that I would necessarily have to stop it, because if we stop it and she gets another or current pulmonary embolism, that actually endangers the mother's health. So I would probably incline to prioritize the mother, for example. Do you agree with me? Or anybody else? I will have any other suggestions or any.
Reasonable. It looks very reasonable. Yeah. It's just the question if this case goes to court, to some legal problems, how will you be able to stand your position in a court?
Can I say something? Can I say something? Can you hear me?
Yes, please. Yeah, of course. Go ahead.
Right. So first of all, hello to everyone, because this is my first time online today with you, and I'm very happy to see some friends. Hello to Professor Khalil. So just a quick comment on what you just said, Asma. I think we should start with reviewing the reasons why that patient receives aspirin and low molecular heparin, because plenty of patients they receive aspirin and heparin without any good medical reasons. So I think that would be the first thing to do. And then it's very important what you suggested. We have to prioritize the mother. And the evidence of aspirin causing the hemorrhage in fetuses is very, very low. So still, the advantage of aspirin in pregnancy is much, much higher than the risk. So I will carry on with aspirin if the mother has good reasons to take it.
Absolutely, I would agree with you. And as I mentioned, I think it's very likely to be incidental finding, or the cause of the fetal intracranial hemorrhage is different. It is true that in many cases, more than half of the cases, we don't find the cause. Even with after all the investigations, we don't find an explanation why this baby has intracranial hemorrhage. But I think it would be reasonable to investigate first, look for other causes. As you said, review why the indication for this woman being on aspirin or low molecular weight heparin. Is it a stronger indication, or is it just a weak indication? In this case, would be reasonable to stop it. I also think that if it is related to aspirin or heparin, you would expect that the mother herself would have some maybe sort of symptoms of bleeding before you actually see the fetus have intracranial hemorrhage. Okay, fine. We have quite a few questions, so let's move on. Theo, in France, it was common practice to replace aspirin by low molecular weight heparin after the 17th or 19 weeks for avoiding hemorrhages. Do you see less hemorrhages with low molecular weight heparin? It's interesting that they replaced aspirin by low molecular weight heparin. I mean, it's certainly not a practice in the UK. Is it a practice in other countries, Poland, Ukraine, or Vienna? I mean, I'm not sure, Gregory, you would know, because that's sort of obstetric management. But you work so closely with the team in Vienna, so you might want to comment. But what's the practice in Poland, Prashik?
Again, if we talk about high risk of preeclampsia, we have strong evidence that aspirin actually reduces the prevalence of preeclampsia. So there's no evidence of exchanging aspirin with heparin. So I would not do it because you still have the risk of bleeding. Well, even if it's very minute, but still, because both these agents, they influence clotting. But if you really want to decrease the risk of preeclampsia, it's the aspirin, not the heparin, that you should use.
Yes, absolutely. And this is the rest of it. It's clear that we do have evidence from randomized controlled trial, the aspirin trial, that aspirin does reduce the risk of preeclampsia in women who were found to be at high risk following first trimester screening. We don't have that level of evidence for low molecular weight heparin.
Asma, can I ask you one question? Because I think this question will relate to the question from the person who asked it. What would you do if a patient with high risk of preeclampsia was allergic to aspirin? Would you recommend heparin?
That's a really good question, and I did come across a pregnant woman who was allergic to aspirin, and she had first trimester screening for preeclampsia, so she would be eligible for low dose aspirin according to our protocol. But in her case, actually the risk, I think, was it wasn't very high, and certainly I don't think that we would replace aspirin with low molecular weight heparin. Low molecular weight heparin is, the mechanism of action is very clear, is it is antithrombotic, while actually the mechanism of aspirin in reducing or preventing preeclampsia, it might not necessarily be antithrombotic. So, and aspirin is not really, to some extent, we never give it because of the risk of thrombosis. So in this case, for this woman, I didn't really give her anything. I said, well, let's monitor your blood pressure and manage you. And I think the fact that she's have allergy to aspirin, I wouldn't sort of want to give her aspirin just because she was found to be a high risk for preeclampsia, because it is still true that the majority of women who will be found to be positive screening for preeclampsia, according to the algorithm, will not develop preeclampsia. So,
Agree.
so I think in terms of the, and she had really a very clear history of, I think it was anaphylaxis or something to when she had aspirin, which is very rare, but certainly I think risk-benefit ratio, I felt that I don't think I would give her aspirin based on that.
Maybe I can contribute one aspect to this discussion. By analyzing our data of fetal brain hemorrhages in our center, and we had on MRI about 110 cases. There were 4 reasons which popped out to be kind of somehow related to that hemorrhage. Most very frequent, interestingly, were the Chiari cases, where we found blood degradation products in the ventricle. Very frequent, we found it in premature rupture of membranes and or infections. And the fourth condition was twin transfusion syndrome. Aspirin or maternal states did not seem to play, at least in our cohort, a huge role as risk factors of those 110 hemorrhages.
I think this is really good comment, Gregor, and thank you very much, because I really think that probably MRI is more sensitive to intracranial hemorrhage compared to ultrasound. I think certainly we would probably miss particularly sort of minor bleeding in the brain or focal bleeding, while actually the MRI would be more sensitive. The association between aspirin and the risk of neonatal intracranial hemorrhage, I don't think it's a very strong association. Certainly, we had access to large data from the United States, and when we adjust for the potential risk factors, that was the association was no longer significant. So I don't think it's a very strong association, or I don't think it's an important risk factor that we have to worry the patients about this risk. Because aspirin, we've been giving aspirin for years, and we're not really seeing a lot of babies with intracranial hemorrhage. So I feel that if there was an important association, I suspect we would have noticed that by now, because we're giving aspirin like lollipops nowadays.
Yes.
Okay, fantastic. I think it's really good discussion. So thank you very much, and please chip in if you want to have any contribution or any comments. There's another question from Mike, and it's not necessarily about intracranial hemorrhage, but it is about MRI. So I think it's probably a fantastic opportunity that Gregor is with us. So the question: would you recommend doing MRI in case of corpus callosum anomaly? And if you do, what would be the ideal timing in pregnancy? I think you're on mute or something. We can't.
Thanks for the question. It's essentially not really closely related to the term and topic of hemorrhages. I just want to, at this stage, say that there are some forms of so-called callosal agenesis where we see the anterior part and the posterior part of the corpus callosum present, and the middle part is missing. And those are the cases which are secondary to brain injury or hemorrhages. So there are forms of callosal damage secondary after hemorrhage or ischemia. That's something just, there is a connection. But the true normal, what we know, type of callosal agenesis, it really depends. The answer, it depends where you're practicing. So if you need decisions, if you need kind of a plan before 24 weeks, it's from my standpoint totally okay to do fetal, or it's really helping you to do fetal MR before 24. If you're in a setting where you have time, you may delay the MR appointment at later stages where you get a more complete image. But be aware, in my experience, after 32, 33 weeks, I feel that the diagnostic sensitivity of MRI and brain malformations goes down, because polymicrogyria at 34, 35, 36 weeks is really often hard. And yesterday I came across a case with periventricular heterocopia, which I missed at 37 weeks, so a very late stage. So it's really hard even at the very, very, very late stages.
It's a really interesting comment, because I didn't know that. I didn't know that the sensitivity of the MRI goes down after 30, late in pregnancy. I didn't realize that. So I certainly learned something new today. So thank you, Gregor. Why do you think so? Why would be the explanation?
Well, we have a window, I think, of opportunity where ultrasound is limited a little bit through the fontanelles and the ossifications, which is like 30 to 35 weeks, I would say. Their MRI is quite good because the external CSF spaces, the space around the brain, is quite wide, so we can have a good look at the brain. But then the brain gets crowded, and we see more and more sulci and gyri, and also the signal at late stages compared to a neonatal MRI, like I'm talking about really close to birth, like 36, 37 weeks, just very close to birth, the signal is not optimal. And this is really, at this stage, it's in my experience, very hard to be certain with the call of polymicrogyria, for instance. So I feel in the very, very end stage of MRI, we also, our sensitivity goes down a little bit. So the paradigm earlier is not so good and less sensitive. I think we cannot uphold this. Early MRI is good. Then we have basically the period where MRI is really very good. I would think that's between 24 and 34 weeks. This is the best time period. Because the babies do not move a lot during that time period. We have time and we can see the brain very nicely.
May I ask Gregor another
Sure.
question? With very early MRI around 20-21 weeks, there is a question of experience, of operator experience, or it's a limitation of the method of the modality?
Both a little bit. But I would also say that experience is the most important factor. You really need somebody who knows to deal with fetal motion and adopt the sequences in a good way. I feel that the modern 3 Tesla machines with the better resolution now are offering you even more details at the early time points. And the third reason is you just need to also feel comfortable with looking at these early brains. And in some countries, radiologists or people working on MRI are just simply not seeing these early cases. They are used to the later ones, so they feel uncomfortable with the early ones, and that's something you need to take into account.
Thank you very much. May I ask about, again, this corona case? Did the lady had actually respiratory failure? Did she need, there was maybe a factor of hypoxia, respiratory support?
Yes, clearly the one case I showed with the post-mortem, the baby who died, the mother was severely affected, and it was in the intensive care unit, needed resuscitation, and finally died, and also the baby died. But that was a very extreme case, I have to say. So most of the other cases were rather mildly affected.
And can I just maybe follow up on this? Was it Delta? Was a Delta strain?
Unfortunately, in my memory, the severe case, the severe course was an exceptional Omicron course, but unfortunately, I mean that occurs from Omicron can be extreme in a certain fraction of cases, but I think that's an absolute exception.
And was she vaccinated?
This lady was not vaccinated, I remember.
Yeah. Okay, so back again to two questions about the corpus callosum and the MRI. I mean, I had a case recently that had a confirmed congenital CMV infection and had an MRI in one of the best centers really in the UK. And the MRI, and that was really at about 36 weeks, so really late in pregnancy. And there were some sort of minor changes in the temporal lobe with echogenicity, hyperechogenicity, but there were no cysts. And the baby, she delivered, I think, about maybe 2 weeks later, and the postnatal cranial ultrasound identified cyst in the brain. Do you think that's a false negative result on the MRI? Or do you think that's it can't be a false positive result on the postnatal imaging?
No, I feel that the postnatal, I would trust the postnatal imaging. It's in that case, it's important to review the images. On MRI, it's like a lot of people feel that MRI has no artifacts and it's always brilliant. We also here in Vienna, we have a certain fraction, fortunately not too many, but a certain fraction of catastrophic quality MRIs where we are totally unhappy with those. So it really depends on the situation and also even on that specific examination. And it's of course possible that we might miss some small cysts with a transvaginal neurosonography and the good linear resolution of your transducers. You might pick up even some smaller cysts better than MRI. I mean, that is would be very interesting to really compare those modalities on a very high level.
It's very assuring to hear that from you. That the fact that actually sometimes you, even one of the best centers in the world for MRI, that you get good quality MRI. What about the agenesis of corpus callosum? Because if you look at the literature, it's reported in cases of congenital CMV infection, but I've never seen a case, even when they're quite severely affected, that they had agenesis of corpus callosum. Have you ever seen that?
I also would say that no, I have not seen it. I have seen changes to the corpus callosum, but throughout that, I think they are secondary. So if you really would have an early CMV infection affecting also the cortical development, leading to polymicrogyria, abnormal neurons, and these neurons have then abnormal axons, and of course they might be disguided, and the corpus callosum is thinner, smaller, maybe a little bit dysmorphic, but in a way that the corpus callosum is entirely missing, that's very, very uncharacteristic for CMV.
Okay, that's reassuring. And maybe one last question about this MRI.